Hello everybody. So today in this video we are going to see a brief about viral infections which will be useful for you on NEET MDS 2024. So let's just see what all topics we'll discuss. So we are going to discuss about four main viral infections that cause oral lesions. So these are HSV, herpes simplex, VZV, varicella zoster, HPV, human papillomavirus, and EBV, which is Epstein-Barr virus. So let's get to see one by one. So HSV. So this is a herpes simplex virus. So it can cause oral lesions and it is the most common organism to cause oral lesions. So it is divided into two main categories, that is primary and recurrent herpetic stomatitis. The primary hepatic stomatitis, it typically affects children with the age of 1 to 5 years. Okay, this is important. So it affects children with the age of 1 to 5 years. So the presenting symptoms will be sudden fever, which is high fever, and malaise, drooling, anorexia, sore throat, and cervical or submandibular lymphadenopathy. So these are the presenting features, that is clinical features, which can be seen in the primary hepatic stomatitis. Then coming to the oral findings, which we can see are the vesicles. The vesicles are seen. So oral cavity vesicles are seen, so which progress to pustules, then become ulcers progressive. So they are usually seen on gums, tongue, palate, buccal mucosa, and lips. So they are surrounded by erythema or edema. Okay, they can be extremely painful and lead to difficulty in eating and drinking. So these are the oral findings and clinical findings of primary hepatic stomatitis. Then coming to recurrent hepatic stomatitis. The recurrent hepatic stomatitis, from the name itself, you can see that it is occurring because the recurrence of the infection, but that is it is seen in adults. So when the child is affected with primary hepatic stomatitis and he is growing into the adulthood, because of the previous infection in his childhood, there can be recurrent herpetic stomatitis. So this is because the herpes virus is present in the latent stage in the person, right? So the presenting symptoms may be milder than those of the primary infection and may include tingling, burning, or itching. Okay, then oral findings will be similar to that of the primary infection, but may be clustered in a smaller area and typically involves the lips and vermilion border. So the vermilion border is typically involved in recurrent herpetic stomatitis, right? Then coming to the microscopic features. So the microscopic features include the early lesions, especially the early lesions. There is intracellular ballooning degeneration. So intracellular ballooning degeneration may be seen in the early lesions, which with multinucleation of epithelial cells and cow dry inclusion bodies. So this is a one more important, very important. Okay, make a note of it. Cow dry inclusion bodies are seen in primary hepatic stomatitis. So they are present within the nuclei representing viral replication site. The same is given in the picture here. The cow dry inclusion bodies are seen. Then acute inflammatory infiltrate in the lamina propria. Then in the later lesions, what happens? The intraepidermal vesicles are filled with CS fluid and neutrophils, and subsequent rupture of vesicles, which might lead to ulceration with fibropurulent exudate, and extensive necrosis and regeneration of epithelium can be seen. So the main important microscopic feature for the exam now you can remember is Cowdry inclusion bodies, which are seen in early lesions of herpetic stomatitis. Right? Then coming to the management. So how do we manage? Since it is a viral infection, we can go with antivirals, right? So, but these lesions are self-limiting and may resolve within 7 to 14 days. Okay, some might resolve without any treatment, but for some, due to excessive pain and inflammation, we can just aim to resolve their pain and inflammation by some giving topical or systemic pain medication and anesthetics or some soft foods like that. So in severe cases only, we go for antiviral therapy with acyclovir and valacyclovir. Okay. So these are the most important points for your 2024 exam. So let's just see some images also so that if they give an IBQ question, you can easily solve them. So the HSV, primary infection. So here you can see the lesions given here are the primary herpes simplex 1, painful and diffuse, irregular, crop-like ulcerations you can see throughout the oral cavity. Right. This is the recurrent one. Okay. So this is the recurrent one. Here you can see crusted lesions on the lip. So crusts are seen in recurrent infection. And here you can see the palatal lesion. Right. So these are images you just keep in mind so they can be asked you in the IPQ question. Then coming to the question which we will discuss now. So a 2-year-old child presents with fever, drooling and difficulty in eating. On examination, the child has multiple clusters of painful vesicles on the lips, gums, palate and surrounded by redness and swelling. So cervical lymph nodes are also enlarged and tender. What is the most likely diagnosis? So the child here is a 2-year child, right? We are only seeing clusters around oral cavity. When we are seeing clusters around oral cavity, active ulcers can also be the differential diagnosis. But since the child is just 2 years old, we can go with primary herpetic stomatitis, right? It is mostly herpes lesion. Then coming to the other question, which of the following statements about HSV recurrence is true? Recurrences become more frequent over time. Is it? No. It doesn't become more frequent. It might recur once in the adult life or twice, but it's not more recurrent type of infection. Antiviral therapy can prevent all future recurrences. Again, it cannot prevent all future recurrences. Okay, it will just subside the viral replication. Then HSV infection can permanently damage the nervous system. No, it cannot permanently damage the nervous system. Then individuals with recurrent HSV can transmit the virus even when no lesions are present. Absolutely, they can transmit. Okay, even when they are lesion free, they can transmit the infections. Okay, so this will be the correct answer for this question, right? Then let's just move on to the other virus. What is your favorite virus? Everyone of you have might be affected with this virus. That is varicella zoster virus, which is a chicken pox. Right. The primary infection includes chicken pox, and the reactivation lesions include shingles. Okay, the chicken pox, which typically occurs in children and young adults. So the fever, malaise, fatigue, and itching are present. So these are the typical lesions which are seen in chicken pox. You can see crusted lesions, right? There will be a progressive rash. That is, the rash starts and in one place and then it progresses to the entire body. So where the rash starts primarily is in the face or in the trunk region. Then it spreads to the entire body. Then the lesion progression is also there in chickenpox. The lesions might be, first of all, it might be red macules or papules, and then it might become vesicles, and then it might become pustules. Like most of them recognize it when they become blisters, right? Because blisters are very big painful and the pus is oozing out, and eventually they form crust. So these are the crustic lesions that are seen here. So then oral lesions. So did you ever get oral lesion while having the chicken pox? You might have got it, but you don't remember, right? So usually develop few days after the skin rash. Okay. So they appear small painful vesicles on tongue, palate, gums, buccal mucosa, and even on lips. So these vesicles eventually break down and form shallow ulcers. Okay. So these are the main important clinical findings and oral findings in um, chickenpox. So let's just see about shingles. Shingles is a reactivated infection of chickenpox. That is, this virus will also be latent, that is dormant stage, and when it is getting reactivated, it will show some symptoms. So why it will get reactivated? It will get reactivated in some older adults or in because of due to immunocompromised individuals. Some cases where there were recorded where before COVID infection, some people got chickenpox reactivation during COVID. So this is because the individual has a lower immunity. So sometimes in some individuals, this virus got reactivated and produced some symptoms of shingles also before producing COVID symptoms. So there may be pain, burning, tingling, and specific nerve distribution. So specific nerve distribution. So which specific nerves are involved in shingles? Which specific nerves are involved in shingles? We'll discuss it. So it is also having a rash, which usually follows the nerve path. Okay, this rash will be similar to chickenpox, but the lesions will be grouped. Okay, the oral lesions occur if the affected nerve involves the face or mouth. They appear in clusters of vesicles on lips, tongue, palate, or gums. So you can see the cluster of vesicles in the image here, right? So which nerve is most commonly affected? So among the cranial nerves, if we take the trigeminal nerve and the facial nerves are the most commonly affected due to reactivation of VZV. So this is an important. Okay, so mostly the first division of the trigeminal nerve, that is the ophthalmic division, is most commonly affected. Then oral lesions are usually smaller, shallower than tetanus simplex, and the VZV lesions can be grouped together like clusters, while HSV are more spread. These are the differentiating points between the VZV and HSV. Here you can see again the tongue involved shingles, right? Clustered lesions, right? Then coming to a question. A 5-year-old boy presents with fever, mild fatigue, and an itchy rash. On examination, you observe numerous pink papules and vesicles of various sizes scattered across his face, trunk, and extremities. Upon examining the oral cavity, you see clusters of small, shallow vesicles on tongue, palate, and buccal mucosa. Which additional finding would further support the diagnosis of VZV? Okay, so he has given all the clinical features. He is just asking to like how you will confirm that this is VZV. What are the additional findings you can see here? So history of contact with someone with chickenpox, enlarged lymph nodes, positive Zank test on skin lesions, or all of the above. See, here we have to understand a very important point. Diagnosis of VZV further, that is confirmatory diagnosis. Here he is asking about how will you confirm? Confirmatory diagnosis is required, right? Not just a provisional thing, right? So history of contact, of course, when the child gets contacted with someone suffering with chickenpox, there are chances that he is also getting chickenpox, but this cannot be a confirmatory diagnosis, right? Then enlarged lymph nodes. Enlarged lymph nodes can be because of any of the infections, right? It's not particularly related to the chickenpox. Then coming to positive ZANK test of skin lesions. So when ZANK test is performed with the skin lesions of this boy, that will be positive. The ZANK test will show what it will show: multinucleated giant cells. So the XANT test is used to confirm the multinucleated giant cells which will be appeared in the chickenpox infection. So let's see what are the things we can see. So the changes are, as we have discussed, multinucleated chain cells in large cells with two or more nuclei, which is the hallmark of PZV infection. So this is very important in the microscopy. Okay, so here we are having a question on pathology, especially, right? So their presence in sphere is suggestive of PZV and can help differentiate it from other viral infections. Okay, and acantholytic cells can also be seen because of their loss in their intracellular adhesion and leading to separate and formation of vesicles. So it's not specific to VZT, but their presence along with the multinucleated gene cells strengthens the diagnosis towards VZV. Right. So this is a very important point you have to keep in mind for your NEET MDS 2024. Then coming to HPV, human papilloma virus. So the types of oral lesions that this human papilloma virus produces are condyloma acuminata, focal epithelial hyperplasia, and verruca vulgaris. So here we will discuss the differentiating points, mainly focus on differentiating points. Okay. So these are the condyloma acuminata when we come. This is the most common type and in the mouth and appearing as small fleshy cauliflower-like growths. So this is the important one, right? Cauliflower-like growths with HPV infection is seen in condyloma acuminata. They occur on the tongue, palate, tonsils, and tongues and gums. Sorry. So focal epithelial hyperplasia. So focal epithelial hyperplasia appears as small, flat, white patches. So this has one more distinguishing factor. Both are caused by HPV, but they are producing different kinds of clinical lesions. So these are the main important points which we have to note down to arrive through the differential diagnosis of the lesion, right? So it can develop on tongue, gums, and inner cheeks. They are usually painless, harmless, but can sometimes be mistaken for leukopenia. Then verruca vulgaris, it is nothing but common warts. You know how warts look like, right? They are the cluster of small dots like things. So they are mostly rough and bumpy, and they are not directly linked to the cancer, but they are uncomfortable and are of cosmetic concern. So they can occur on lips and the oral mucosa also, right? So these are the important points around the HPV lesions. Okay, so the same can be seen in the images here. So from the description we have been given, so this is looking like a gobi, right? Cauliflower. So this will be condyloma, right? Then these are these are looking like some flat lesions. These are not white, but they are looking like flat lesions, right? So these lesions can be suggestive of focal epithelial hyperplasia, right? And these are the warts. Warts is verruca. Okay. So these are the important images you can keep in mind. Next, coming to the microscopic diagnosis. So in condyloma acuminata, you will see stratified squamous epithelium with xanthosis and poliocytosis and enlarged nuclei with prominent nucleoli. And focal epithelial hyperplasia also you will see acanthosis, but with parakeratosis. Okay, and occasional poliocytes. And verruca vulgaris similar to condyloma acuminata, but with thicker parakeratosis and less poliocytosis. So these are some points you can just remember. Okay, then the treatment, how we will do. If it is verruca vulgaris due to cosmetic concern, we can remove it with the electrocautery, electrotherapy, right? Then sometimes we can use laser ablation or cryotherapy also. And topical medications like salicylic acid and podophyllin are topical medications which can remove or shrink HPV lesions. Okay. So then coming to a question here, a 30-year-old woman presents with multiple painless fleshy growths on her tongue and palate, and she reports having unprotected oral sex with a new partner several weeks ago. On examination, the lesions appear cauliflower-like and range from 2 to 5 mm in size. What is the likely diagnosis based on the clinical presentation? The most important one more thing is that how is HPV transmitted sexually? So HPV lesions are transmitted sexually since they have given that she was involved sexually with the unprotected sex. So and the lesions are cauliflower-like. So we can arrive to condyloma acuminata due to HPV, right? Then coming to the next one, Epstein-Barr virus. Epstein-Barr virus, it develops oral lesions only when immune system suppression is happening in the individual or when the reactivation of the virus is done. So the types of oral manifestations which we see are hairy leukoplakia, which we can see in the tongue here. So this is the most common and most uh, commonly asked question in the NEET MDS also. So the hairy leukoplakia, which is a precancerous important white patch, most commonly involving the tongue and can also be found in buccal mucosa, palate and gums. So it is characterized by elongate papillae which resemble fine hairs. So associated with immunosuppression, particularly HIV or AIDS patients with EBV reactivation. Then lymphoepithelial carcinoma. It is a rare epithelial tumor which is with a link to EBV infection, more common in the nasopharynx. Okay. Then coming to the one more commonly asked question, oral thrush. Oral thrush, which is also oral candidiasis, right? So it is not directly caused by EBV, but it is caused by Candida albicans. So if EBV infection leads to immunosuppression, it can also lead to oral candidiasis. So how do they appear candidiasis? White patches with underlying redness on tongue, inner cheek, and the palate. So you can see the tongue here. And the diagnosis is through clinical examination, biopsy. Biopsy is done to rule out carcinoma, right? Rule out carcinoma and other infections. Okay. Once these are ruled out, then only we can arrive to the diagnosis of EBV. Okay. And one more thing is EBER testing. So this detects the EBV encoded small RNA in tissue samples to confirm the EBV involvement in the lesions. Okay. So these are the important points around the EB. The three lesions which we can see in EBV are hairy leukoplakia, important, oral thrush, important, and one more thing is carcinoma. What carcinoma? It is lymphoepithelial carcinoma, right? So you have to remember this. And let's just dive into the question once. And a 50-year-old man with a history of uncontrolled diabetes. Uncontrolled diabetes will show you that the patient is immune suppressed. Okay. Whenever you find in the questions like uncontrolled diabetes, you just have in mind that the patient is immune suppressed. So presence with multiple white hairy patches on the tongue. He recently experienced pneumonia and received immunosuppressive medications during the treatment. On examination, the patches are thick, wrinkled, and appear slightly tender when scraped, which additional tests would confirm the diagnosis. Since the hairy patches are on the tongue, the diagnosis mostly we are seeing is hairy tongue. And since they have told that the patient is already immune suppressed. So immune suppression and inheritance, these lead to the organism EBV. What is the confirmatory diagnosis that we can use here? So they have given EBR testing, viral culture, fungal smear, and biopsy. So EBR testing. So EBR testing, of course, it will detect EBV. Okay, but the confirmatory diagnosis that this is caused by EBV only. It is not any cancerous condition. Is not given by EBR. Okay, and viral culture is of no use. Okay, and fungal smear is also of no use because we have seen hairy lesions and mostly it will not be candidiasis or any other thing. So fungal smear will not be used. Biopsy. Biopsy will give you a definitive diagnosis as we have discussed. It will give you definitive diagnosis that it is caused by EBV. Okay, and the treatment can also be proceeded based on the features that are seen. Yeah. Once carcinoma is ruled out, we can proceed with the treatment. Okay, so these are the very important points you have to know around viral infections. So okay, so you can just revise it like this, and you can also revise with your material that you have studied till now. So let's just meet in another session like this. Thank you.